Hello, everyone. Thank you for the opportunity to make this presentation. Today, I will talk about sequential multiple assignment randomized trial with a short name SMART trial. This is a novel clinical trial design for compare multiple adaptive intervention. I will introduce the concept, give several examples, and talk about the methods to design and analyzing this trial. So the concept of personalized medicine is an increasing popular topic in today's healthcare research. Individualizing patient care is particularly important in managing chronic diseases. The patient care in chronic disease typically take a long period of time, during which multiple clinical factors vary across different patients at a different time within the same patient. These clinical factors can be medication adherence, side effects, intermediate response, and a history of previous treatment patient received in early of the period. The key to success in managing chronic disease is to design a flexible treatment strategy that can adapt to patients' personal information. For example, we need a strategy to help adjust the inherent heterogeneity across different patients and help control the variability within the patient across time. Ideally, the strategy should be able to help us improve the individual compliance to the treatment patient receive and minimize the burden and the cost. So this kind of study strategy fits the paradigm of personalized medicine. The clinical practice of chronic disease, such as cancer care and depression management, clinicians often need to make a sequence of treatment decisions throughout the entire course of patient clinical care. This decision usually adapt to a patient's treatment and covariant history in the previous stage in the same treatment. So the adaptive intervention formalizes the mechanism of such a sequence of decision making. Here is an example of two-stage adaptive intervention designed for the newly diagnosed patient with diffuse large B-cell lymphoma. This is originally reported by Haberman in 2006 and published in JCO. Under this adaptive intervention, patient was first given CHOP, a combination of 4 chemotherapy agents for 8 cycles at stage 1. At the end of stage 1, the patients were classified as responders and non-responders. Here, response is defined as complete remission or partial remission, and non-response otherwise. For non-responders, they will be given rituximab, they will be given GCSF for supportive at the stage 2, and for responders, they were given rituximab for 6 months as a maintenance. This is one adaptive intervention, and the intervention can be recommended to all the patients with newly diagnosed diffuse large B-cell lymphoma. A patient under this adaptive intervention in clinical practice can possibly receive 2 treatment sequences. One is CHOP response, rituximab, and the other is CHOP no response, GCSF. Specifically, which treatment sequence a patient will follow in practice depending on the value of intermediate response observed on this patient. An adaptive intervention typically has 4 important components. First, it has multiple treatment stages. Each treatment stage refers to an interval of time during which a patient receives one specific treatment. For example, in this case, we can see at the stage 1, all the patients will receive one treatment, which is CHOP, while at the stage 2, a part of the patients will receive rituximab, and rest of them receive GCSF. In the practice, researchers can define the number of stages of adaptive intervention depending on the feature of patient care and the interest of study. Also, an adaptive intervention has a sequence of decisions regarding to the treatment selection. For example, in this case, at the stage 2, a decision needs to be made is if a patient failed to respond at the end of stage 1, which treatment should be selected for next stage? Well, if the patient achieves stabilize, which treatment should be selected for maintenance. The stage 1 treatment here is not adaptive to any baseline information, but surely we can design another adaptive decision at the stage 1. For example, we can give patients with comorbidity a certain treatment, and for those patients without comorbidity, another type of treatment. In that case, we will see 4 treatment sequences in this adaptive intervention, which is more complicated. Also, adaptive intervention has a set of treatment options at a decision-making point. So we can choose different treatment based on patients' different clinical information. This option can be dose, type, or timing of medication given to patient. If there's only one treatment option, then differentiation based on different clinical condition is not meaningful in adaptive intervention. Also, we have tailoring variable, which is the variable that contains information to support the decision-making in the adaptive intervention. For example, in this case, the tailoring variable that supports the decision-making at the stage 2 is the response to CHOP measured at the end of stage 1. So we're based on the patient's response to decide which treatment we give to this patient at the second stage. A commonly seen tailoring variable in adaptive intervention include baseline covariates, previous treatments, side effect, and medication adherence. So with the example I give in previous slides and the 4 important components, it's easy to understand the official concept of adaptive intervention here. Adaptive intervention is a multi-stage treatment strategy consisting of a sequence of decision-making rules, 1 per stage of intervention, which specify how to adapt the treatment selection according to individual patient's clinical history of treatment and other covariates. So statistics play an important role in adaptive intervention research. It provides an evidence base, or we can call this data-driven framework, to help us optimize the decision-making for treatment selection for individuals in adaptive intervention. Also, it helps us identify the optimal adaptive intervention, leading to the best outcome in the long run. A natural question in adaptive intervention research is whether or not an adaptive intervention identified in the study is better than the others. So in terms of statistics, we can translate the question into whether a particular adaptive intervention can lead to a better average outcome in the long run. To answer this question, we need to conduct a causal inference based on the sample data collected from study. It can be 2 types of study. One is observational study, and the other is randomized clinical trial. In an observational study, the data is relatively easy to obtain and with lower cost. However, the reason that a patient receives a specific treatment in an observational study is not always completely documented. So the conclusion made based on observational data sometimes can be biased potentially. Unfortunately, the existence of the impact from a measured confounder in observational study is not numerically testable because we don't even have the data. So we cannot conduct the test. So the finding in the observational study need to be verified using the result of randomized clinical trial. In the randomized clinical trial, the reason that a patient was assigned a treatment is because it's a result of randomization. So the randomization procedure can help us rule out the impact from a measured confounder. So we can use the data directly to support the causal inference. Today's presentation, we talk about the design for randomized clinical trial. Sequential multiple assignment randomized trial with a short name SMART trial is a clinical trial design that can be used to compare multiple adaptive interventions. Such a design randomly assigns patients to a collection of adaptive interventions that may overlap in terms of treatment decision. So by virtue of randomization, this design provides information, allow us to compare multiple adaptive interventions directly in the study. You can see here is an example of 2-stage SMART for those lymphoma patients. Under this design, patients who enroll in the trial were first randomized to receive CHOP or R-CHOP, which is rituximab plus CHOP for 8 cycles at the stage 1. At the end of stage 1, an intermediate evaluation was given to each patient, and the patients were classified as responders and non-responders based on the definition we mentioned in previous slides. For non-responders in this study, at the stage 2, they all given GCSF for supportive, while for those responders, they will be randomized again to receive rituximab or observation for maintenance at the stage 2. We can see there are 6 treatment sequences embedded in this design diagram, presented as the arrow goes from left to the right, and we denote it by sequence A, B, C to F. For example, sequence A is CHOP, response, rituximab. So a patient who completes this trial will follow one of these 6 treatment sequences, depending on the result of randomization and the intermediate response. The previous example of 2-stage adaptive intervention is highlighted in red in this design diagram, by which we give patient CHOP at the stage 1, rituximab at the stage 2 if the patient responds, and a GCSF at the stage 2 if the patient fails to respond. So we denote this adaptive intervention as A plus C here because it consists of 2 treatment sequences, sequence A and sequence C. Similarly, we can identify another 3 adaptive interventions in this design diagram. Each adaptive intervention consists of 2 treatment sequences, one for response and one for no response, and both treatment sequences share the same stage 1 treatment. For example, we can identify another adaptive intervention by giving people CHOP at the stage 1, observation at the stage 2 if the patient responds, and a GCSF at the stage 2 if the patient fails to respond. If you look at the design diagram, we can see both these 2 adaptive strategies, they actually share the same treatment sequence, which is sequence C here. So that is to say, for those patients who receive CHOP at the stage 1, fail to respond, and receive GCSF at the stage 2, they actually contribute information that help us to evaluate 2 adaptive interventions. This feature makes SMART a very efficient design, but also introduce some complexity in statistical inference. I will talk more detail about it. The curse of dimensionality is the major concern of SMART design because the total number of adaptive interventions identified in SMART increase exponentially as the number of treatment options and the intermediate response categories increases. For example, in this study, we can identify 4 adaptive interventions. However, if we modify this a little bit, we increase 1 treatment option for those patients who fail to respond to stage 1 treatment. So the total number of interventions will increase immediately from 4 to 8, which is substantial. This feature has big impact in the statistical inference in terms of controlled false positive finding, and I will talk more about it. So in a clinical trial practice, there are some other clinical trial designs, more or less, that share some common feature with SMART. The similarity between SMART design and this design sometimes cause confusion for the clinical trialists who get to know this concept at the beginning. These are also the playground that we statisticians receive a lot of questions from our clinician collaborators. Today, I will compare SMART design with 2 clinical trial designs, crossover and adaptive design. So by making these comparisons, we further demonstrate the feature of SMART design here. So first we'll look at the crossover design, which is a repeating measure randomized clinical trial design, that each individual in this study will receive varying treatment sequence across multiple stages. Here is an example of crossover study compared to fixed treatment A and B. At the beginning of stage 1, patients were randomized to receive A or B at the stage 1. At the end of stage 1, the primary outcome was measured for each patient, and then patients will switch from A to B or from B to A at the stage 2 and repeat the same story at the second stage. So operationally, crossover design is somewhat similar to SMART because in this design, patients also receive different treatments across multiple stages. However, we can clearly separate these two designs from three aspects. So first of all, crossover design is motivated by improved efficiency and reduce the total sample of the study. But the goal is still try to compare two fixed treatments, or we can call this two non-adaptive interventions. For example, in this case, although different patients receive treatment sequence of A to B or B to A, this design is just try to take two measures from each patient, and the goal is to reduce the total sample size, but still with the primary hypothesis to compare treatment A and B. However, in the SMART, it's designed to compare multiple adaptive interventions, which is different from crossover. Also, in the crossover design, the treatment assignment only depends on the baseline randomization. In this case, patients either receive sequence A to B or sequence B to A, but which sequence the patient will follow completely depends on the baseline randomization. Once the trial is started, we never change it unless the patient drop out. However, in the SMART, the story is totally different. Only the set of decision rules about how to assign the treatment is pre-specified at the baseline, because the randomization is conducted sequentially at the beginning of every stage. So until the last decision is made, it's unlikely to know each patient follow what kind of treatment sequence. So also, the major pitfall of crossover design is something called carryover effects, which is the prior effect of treatment A or B can be confounded with the succeeding treatment effect of B or A. So in this case, if the carryover effect exists, so when we look at the primary outcome measure at the end of stage 2, we won't be able to know if the primary outcome is purely because the treatment patient received at the stage 2, or it's partly because the treatment a patient received at the first stage, which is reduce the power of the study. So to avoid the contamination of carryover effect, in a crossover design, it typically inserts a unique component called washover period between two treatment stages. The key to set up a washover period is to control the time window large enough to eliminate any possible carryover effects. On the other hand, in order to make the trial efficient, once this requirement is met, we also need to try to control the time window as short as possible. In the SMART, it's different because the SMART design is trying to compare the effects of adaptive intervention. And the effect of adaptive intervention is possibly due to the interaction effect between the treatment a patient receives in different stages. So in SMART, we do not set up any washout period to try to rule out the carryover effects. Another term that sometimes gets confused with SMART is adaptive design. In fact, adaptive design is an umbrella term that covers a family of randomized clinical trials. The members in this family including continuous reassessment design, sample size recalculation design, or adaptive randomization design. All this design has one common feature, which is they try to modify some of the design aspects, such as total sample size, randomization scheme, based on the result of interim analysis. The goal of this adaptive design is try to improve the overall quality of patient care in favor of those treatments who show better evidence of better efficacy or less toxicity from the interim analysis. So the between subject information is adapt. While in the SMART, what we adapt is the within subject information between different stages. But a common design element like total sample size, randomization scheme are all fixed. We do not change it once the study starts. So after introduce the concept of adaptive intervention and the SMART trial, next I will talk about the methods to design SMART and analyzing SMART data. First, I will talk about how to estimate the adaptive intervention value by two methods, maximal likelihood estimator and the inverse probability weighted estimator. Then I will talk about how to conduct the hypothesis test is SMART to compare multiple adaptive interventions. I will talk about pairwise test, also a global test called Omnibus Test. Then I will talk about how to conduct the sample size calculation in designing a SMART trial. So before illustrate the method, first let's take a look at the general scheme of two-stage SMART. This is the scheme that we use to conduct the statistical inference. Patient enrolled in the trial was first randomized to I treatment option at the stage 1. We denote it by T1, T2 to Ti. For each stage 1 treatment, there are a certain number of intermediate response categories. Follow it. In a general SMART design, we allow the number of intermediate response categories to vary by different stage 1 treatment. For example, under T1, we have J1 intermediate response categories denoted by R11, R12 to R1J1, while under Ti, we have Ji intermediate response categories denoted by Ri1, Ri2 to Riji. Similarly, we allow the number of stage 2 treatment options can be varied by different history of stage 1 treatment and the intermediate response. Suppose a patient enrolled in the trial received T1 at the stage 1 and had the intermediate response R11 at the stage 2 based on this design. Patient will be randomized to receive 1 out of K11 treatment option, denoted by S111, S112 to S11K11 here. So in the lymphoma trial I just talked about, we have 2 treatment options at the stage 1. So T1 will be CHOP and the T2 will be R-CHOP because we define the intermediate response for both stage 1 treatment as a binary outcome. So after T1, we'll have 2 bullets here with R11 represent the response and R12 represent no response. Similarly, after T2, we have 2 bullets with R21 corresponding to response and R22 corresponding to no response. For the stage 2 treatment, because we do not randomize non-responders again, so following R12 and R22, we have 1 bullet of treatment option. While for those responders, we will randomize as 2 treatment options. So we'll have 2 bullets here following R11 and another 2 bullets following R21. So data collected from the general scheme of two-stage SMART for a patient can be summarized as a longitudinal trajectory across time, Ux, Vy, where U is the variable representing the stage 1 treatment, X is the intermediate response, V is the stage 2 treatment, and Y is the final primary outcome. So to do the statistical inference, we assume Ux, Vy independent identically distributed, with pi I being the stage 1 randomization probability corresponding to the patient received Ti at the stage 1. Pij is the intermediate response rate corresponding to Rij, given the patient received Ti at the stage 1. And the pi ijk being the stage 2 randomization probability corresponding to a patient received Sijk at the stage 2, given the patient received Ti at the stage 1 and had an intermediate response, Rij. Finally, we assume Y, the primary outcome of interest, followed, given a history of Ti, Rij, Sijk, follow a distribution with mu ijk being the parameter of interest and the tau ijk being the nonsense parameter. So specifically in this presentation, we just focus on the mean of primary outcome as a parameter of interest. Suppose the primary outcome is a continuous variable. Y, given a history of Ti, Rij, Sijk, we follow a normal distribution with mu ijk being the mean of primary outcome, which is the parameter of interest, and the variance sigma ijk squared. So under this framework, each adaptive intervention consists a series of treatment sequences. With each of these sequences, there's a specific mean of primary outcome corresponding to it, and we denote it by mu. all these sequences share the same stage 1 treatment. We define the value of adaptive intervention as a weighted sum of this treatment sequence specific mean, mu, weighted by the intermediate response rate, p. So the value of adaptive intervention can be interpreted as the average primary outcome across all the possible treatment a patient can receive under the adaptive intervention. Now, let's take a look at the lymphoma trial example. Suppose we are interested in calculating the value for adaptive intervention A plus C. We have two treatment sequences here, sequence A and C. So we have two sequence-specific mean, denoted by mu A and mu C. Let P1 be the intermediate response rate following CHOP. So the value of adaptive intervention A plus C can be calculated by P1, which is the probability that we observe a patient who follows sequence A under this adaptive intervention, multiply the mean of sequence mu A plus 1 minus P1, which is the probability that we observe a patient following sequence C under this adaptive intervention, multiplied by mu C. Similarly, we can calculate the value of other three adaptive interventions, as we show in the bottom of these slides. To estimate the value of adaptive intervention, we can use maximal likelihood estimator, MLE. The MLE of theta, adaptive intervention value, can be obtained by plugging the MLE of those intermediate response rate P and the MLE of sequence-specific mean, mu. The MLE of P and mu can be obtained by maximizing the joint distribution of UXVY. Alternatively, we can use another method to estimate the value of adaptive intervention. This is inverse probability weighted estimator, using formula 1 in the top of the slide. Here, W is the inverse probability treatment weights assigned to each patient following complete SMART trial. And the YL is the observed primary outcome, observed in patient L. L is the indicator of each subject who complete the SMART trial with value 1 to n. N is the total number of patients who complete the trial. To build the inverse probability treatment weights, for those patients who follow a sequence do not belonging to the adaptive intervention of interest, we simply give this patient a weight of 0. While for those patients who follow a sequence belonging to the adaptive intervention we are interested in, the weight can be built based on a cumulative product of inverse randomization probability corresponding to all the treatment a patient received in the study. Formula 3 is the formula to calculate the variance estimator of IPWE. We can see this is a function of n, total sample size, W, inverse probability treatment weight, and Y, observed primary outcome. So let's go to the lymphoma trial and see how we construct the weights to calculate the inverse probability weighted estimator. Suppose we're interested in the adaptive intervention A plus C. We have three randomization probability here. Pi 1 corresponding to CHOP at the stage 1. Pi 2 corresponding to rituximab for those responders of CHOP. And Pi 3 corresponding to the rituximab corresponding to those R-CHOP. Pi 1 and Pi 2 will be related to calculate the weights for those patients who follow in adaptive intervention A plus C. For patients who follow sequence A here, they had two randomization in the study, one in stage 1 and one in stage 2. So the weight can be calculated using 1 over pi 1 multiply 1 over pi 2. To make it simple, let's assume pi 1, pi 2, and pi 3 all equal to 50%. So the weights for those patients who follow treatment sequence A will equal to 4. For those patients who follow treatment sequence C, the only randomization happens at the beginning of stage 1. So for this patient, the weight can be calculated by 1 over pi 1, which is 2. While for those patients who follow other treatment sequence not belonging to this adaptive intervention, B, D, E, and F, We simply give them weight of 0, and then we plug in the formula, can calculate the IPWE. So these two methods to estimate the adaptive intervention value, maximal likelihood estimator and the inverse probability weighting estimator, they both consistent estimator and asymptotically identical. So when the sample size of a SMART is large enough, they have the same performance, or at least similar performance. Compared to the maximal likelihood estimator, the calculation of IPWE is relatively simple because we can see the function only involves two components, the randomization probability and the observed primary outcome at the end of the study. So we do not have to deal with the complex structure of SMART. Also, this method is robust to the assumption of data distribution. On the other hand, the maximal likelihood estimator takes the advantage of asymptotic efficiency when the assumption about data distribution correctly reflects the feature of sample data. On the other hand, if the assumption about the distribution do not correctly reflect the feature of sample data, then the performance will go to the opposite way. So we have done a lot of study in this area and gained a lot of experience from the simulation study. For smart design with moderate sample size, when the primary outcome is continuous variable or binary variable, we can feel comfortable about the maximal likelihood estimator and use this one. So we take the advantage of asymptotic efficiency. So next, I will talk a little about the distribution about MLEs, which is the fundamental theory of the statistical inference for comparison. Here, the uppercase theta is the vector of all the adaptive intervention value embedded in a smart design. The lowercase theta is a single adaptive intervention value. The subscript of theta is the indicator of each adaptive intervention, and G is the total number of adaptive intervention can be identified in a smart design. So it can be proved that the MLE of theta follow a multivariate normal distribution asymptotically with variance-covariance matrix sigma. Sigma here is a block diagonal matrix of a series of small covariance matrices denoted by sigma 1, sigma 2 to sigma I. Each of these small covariance matrices corresponding to the MLEs of those adaptive intervention value share the same stage 1 treatment in the study. For example, sigma 1 here is the covariance matrix of the MLEs of all the adaptive intervention start with T1 at the stage 1. These MLEs are correlated to each other due to the overlap in structure, and the correlation varies by study design. To compare multiple adaptive intervention, we can use a pairwise comparison, by which we conduct a series of pairwise tests to compare each pair of the adaptive interventions. The null-hypothesis of pairwise tests is two adaptive interventions have the same value. We can use formula 4 to calculate the test statistics of a pairwise test. Here, for the denominator, we can plug in the estimator of adaptive intervention of two adaptive interventions. It can be MLE or can be inverse probability weighted estimator. So for illustration purpose, to make it simple, from now I just focus on maximal likelihood estimator. To calculate the variance, the denominator, if we try to compare two adaptive interventions, do not overlap with each other in structure. The calculation is relatively easy because it only involves the variance components. When we try to compare two adaptive interventions that are somewhat overlap in the design structure, then the computation will be a little more complicated because you need to involve the cross product, which is the covariance. All this variance and covariance information can be obtained from the estimate sigma here. So next, I will use a real data example to illustrate how we conduct the pairwise comparison. The data was extracted from a study called CODIACS, Comparison of Depression Intervention after Acute Coronary Syndrome. This is a study that aimed to assess the quality of depression care of different management programs. So the primary outcome of the study is back depression inventory, which is a continuous score. A higher level of back depression inventory indicating a more severity of depression. So an adaptive intervention that leads to more BDI reduction from baseline, indicating a better treatment effect. So this is the design diagram of the study. At the stage 1, patients were randomized to receive medication and behavioral therapy for 2 months. At the end of stage 1, patients were classified as responders and non-responders based on the reduction of BDI from baseline greater than 3 or not. And then they will be randomized again to receive medication and behavioral therapy for another 4 months based on different history of stage 1 treatment and intermediate response. This design structure provides data that allow us to evaluate up to 8 adaptive interventions. First, we calculate the estimated adaptive intervention. To estimate the intervention value, first we need to estimate the response rate. First, we need to estimate the intermediate response rate following medication and behavioral therapy. Then we need to calculate the sequence mean following each of those 8 sequences. Then we plug in the formula and calculate the MLE of all 8 adaptive interventions, as we show here. We can see the 5th adaptive intervention has the largest MLE, so we call this observe the best adaptive intervention. For the variance-covariance matrix, because we have 8 adaptive interventions here, this is actually a block diagonal matrix with dimension 8 by 8. The small covariance matrix in the upper left is the covariance matrix of those MLEs corresponding to the intervention following medication at the stage 1. And then we have another 4 adaptive intervention following behavioral therapy and the variance-covariance matrix on the bottom right. So a potential issue of using pairwise comparison to evaluate all the adaptive intervention in SMART is this procedure needs to take into account the multiple comparison issue. Using methods such as Bufferoni correction, which is known to be conservative, when the number of adaptive intervention can be identified in SMART increase. For example, in this case, we can see, suppose we're trying to compare the adaptive intervention, control the overall significant level at 0.5, because we have 8 adaptive intervention. So a pairwise comparison with Bufferoni correction require a p-value less than 0.001a to claim overall significant. The last column of this table gives us all the p-values of pairwise tests to compare each adaptive intervention with observe the best, which adaptive intervention 5. So you can see, by the comparison, although there's one p-value less than 0.05, after Bufferoni correction, we cannot claim overall significant because there are too many adaptive interventions. This problem is particularly significant in SMART because the sequential randomization of SMART always generates high-dimensional data that are including a lot of adaptive interventions. So alternatively, we can use a gatekeeping approach to do the analysis. A gatekeeping approach is a 2-step approach. In step 1, we conduct a global test, or sometimes we call this Omnibus Test, with the non-hypothesis that all the adaptive interventions have the same value. Only if the non-hypothesis of the Omnibus Test was rejected, we move forward to do the selection. Otherwise, we stop analysis and claim there's no overall significance. So here is the formula 5 is how we calculate the test statistics Q for this global test. N is the total sample size of patients who complete the SMART trial. C is the contrast matrix. I will talk about this later, how to construct it. Theta hat is the estimated value of all the adaptive intervention, and the sigma hat is the estimated asymptotic covariance matrix. Under the null hypothesis, Q, the test statistics, we follow a chi-square distribution with degrees of freedom nu, while under the alternative hypothesis, Q follow a non-central chi-square distribution with a non-centrality parameter lambda star. The degrees of freedom of chi-square test can be calculated using formula 6. Here, summation of Kij is the total number of stage 2 treatment option, and the summation Ji is the total number of intermediate response categories. I is the total number of stage 1 treatment option. Let's use the example of CODIACS to see how we conduct the global test. We have 8 adaptive interventions in this study. So the null hypothesis of the global test is all 8 adaptive interventions have the same value. To calculate the test statistics, first we need to construct the contrast matrix. Because we have 8 adaptive interventions, the dimension of this contrast will be 7 by 8, with each column of the matrix corresponding to one specific adaptive intervention. And each row of this contrast matrix corresponding to one contrast to compare a pair of adaptive intervention. In the first row, we compare adaptive intervention 1 versus intervention 2. In the second row, we compare intervention 1 with intervention 3, etc. Once we have the contrast matrix, we plug in the formula with total sample size n, estimated adaptive intervention theta hat, and estimated asymptotic covariance matrix matrix. We can calculate the test statistic Q equal to 36. To calculate the degrees of freedom, let's go back to the design structure here. We have 8 treatment options at the stage 2, 4 intermediate response categories, 2 stage 1 treatment options. So the degrees of freedom equal to 8 minus 4 plus 2 minus 1, which equal to 5. By this means, we finally obtain a p-value of global test less than 0.001 because it's more powerful than the pairwise tests, and we can claim overall significance in this study. Another good thing about the global test is it provides an efficient method that can help us power a smart trial. Here is the general approach to conduct the sample size calculation for a smart trial. To conduct the sample size calculation, first we need to specify with the design structure. Statisticians communicate with the clinical collaborators and finalize the design structure. What will be the treatment option at the stage 1 and the stage 2? How to define the intermediate response, and then we need to set up the randomization probability, pies. Once we finalize the design structure, we need to obtain lambda star, which is the non-centrality parameter, under the alternative hypothesis in step 2. To obtain the value of lambda star, we need to solve the equation of 7. To do this, we need to pre-specify the target type 1 error rate alpha and the target power 1 minus beta. And then we need to calculate the effect size delta using formula A. Here, C is the contrast matrix we just saw. Theta star is the target adaptive intervention value, and the sigma star is the target asymptotic variance covariance matrix. Once we have the value of lambda star and the delta, we divide the lambda star by delta, and we can obtain n, which is the total sample size of all the patients we require for a smart trial. Another good thing about smart trial is, other than this is a very efficient design for comparing multiple adaptive intervention, the study design also provides a very rich information that allow to answer a series of secondary research questions. For example, in this study, the lymphoma trial, the primary interest question is compare 4 adaptive intervention, but we can also use the data to compare CHOP and R-CHOP to see which one provides a better response rate for the patient with newly diagnosed lymphoma. Also, we can compare rituximab versus observation for those responders of CHOP, and compare rituximab and observation for those responders after the R-CHOP. We can do this is because we conduct sequential randomization given different conditions of the patient sequentially in the study. Although the trial was powered based on the primary question, so when we study this secondary question, we may not have enough power to control the study under a very restricted control of the type 1 error. However, it also still provides a very rich, valuable information for those questions. This is another example that we use smart design to improve the design efficiency compared to a traditional randomized clinical trial. Because of the time of limit, I will skip this one. And if anyone who is interested in it, you can contact me after the presentation, and I will be very pleased to talk about it. So in summary, SMART is an efficient randomized clinical trial design that provides data to compare multiple adaptive interventions. Also, other than answer the primary question, it also provides rich information to answer a series of secondary questions in terms of patient care of chronic disease. In statistics, in the last 10 years, many studies has been conducted in this field, and several important papers has been published. So the technique for designing a smart trial and analyzing smart data is getting mature. So it will be a good time to conduct this clinical trial design in the clinical trial practice of medical research. So it has a broad application potentially in the future. These are the reference of today's presentation. Thank you.